All right. The next set of discussions on nutritional diseases. You may think, well, nutrition is not going to really affect what my anesthetic delivery is, and actually that's not the case. What I'm going to try to concentrate on mostly is what is it that it may affect the anesthetic, and how is it that you have to take this into consideration. So nutritional diseases can be, areas of discussion will be obesity, malnutrition, things that's anorexia nervosa, bulimia, binge eating, and vitamin imbalances. And that's what I'm going to concentrate on, some of the problems that we see with anesthesia. Obesity is got a definition. That definition is 20% above ideal body weight, which is a body mass index of around 28 for men, and for women it's 27. This is the actual equation, okay, that I expect you to know for the test. Okay, so that's the body mass index, weight over height. Okay? The body mass index greater than 28 is associated with increased morbidity due to stroke, ischemic heart disease, and diabetes. Okay, there's different kinds of obesity. There's the central, which we call the android obesity, seems to be more physiologically significant. It affects about 1/3 of adults in the U.S., and unfortunately, incidence is really becoming a problem. It's getting worse every year. There's prevalence based on states, so you may want to consider this if you're going to go work in certain states. If you want to see where the obesity problem is a huge, huge risk, this is the area of the country that's very high in risk. Things like Alabama and Mississippi have the highest incidence rates for obesity. That doesn't mean that it's not just allocated to those states. You can actually have cities that have actually a higher incidence of obesity as well. Okay? If you go work in Hawaii, you may think, well, Hawaii Beach, beautiful and everything. It's actually one of the areas that have a very high incidence of obesity in the native population. Okay? Their genetics really are built for protein nutrition. So unfortunately, when they got exposed to carbohydrate nutrition, Micronesians became very morbidly obese. Okay? And it becomes a big issue in obstetrics there. I've had a friend of mine who actually works there in the obstetrical hospital, and he constantly is telling me how much of a nightmare it is for airway there. Okay? So they're constantly worried about it. Obesity is from lipoprotein lipase regulates fat deposition. The central, which is the android fat, is more metabolically active, which is much more of a problem in the sense of causing a more disease process. Stress appears to increase cortisol release, leading to increased central fat deposition, so it's associated with stress as well. Caloric intake is usually excessive. It's greater than expenditure, so your basal metabolic rate accounts for about 60 to 80%. And then if you exercise, you increase the thermic exposure and you increase your basal metabolic rate, you can break down fat much more readily. The problem with our diet is it's so nutrient-rich that you tend to have a much higher caloric intake than you actually expend. Okay? And this happens with individuals, of course, that working many long hours. They don't have enough time for exercise. They have many other additional stressors in their life. That increases their risk of developing obesity. Okay? So what you need to do in this case, it's easy to say but hard to do, is decrease your caloric intake and actually increase your exercise. The problem with is people that are morbidly obese have a lower basal metabolic rate. So they have a much harder time becoming thin again. And for them to stay thin is actually very difficult. They can revert back to bad habits very quickly, and if they don't exercise continuously, their basal metabolic rate, if they can take a smaller meal and they'll still gain weight while somebody else who is in good shape, and same as them almost at that point, they won't gain weight at all, versus somebody who is already obese in the past has a lower BMR, and as a consequence has a higher chance of developing this problem. There's also secondary causes of obesity that you've got to consider, things like hypothyroidism, Cushing's disease, where you get excessive production of cortisol, insulinemia, hypothalamic obesity, polycystic ovary disease. All these just will increase your chances of developing obesity. Okay? Women have known for many years that smoking actually helps control fat, okay? Specifically around peripelvic fat. People that smoke have a lot less fat in that area. Okay? But as soon as you stop smoking, the fat tends to deposit in that area very quickly. There's also eating disorders. They call it binge eating, bulimia nervosa, or night eating disorders where people excessively eat at night, which is the worst time to eat. If you have to have a choice in how you change your diet, the best thing to do for most people is eat heavy in the morning, light in lunch, and almost nothing at dinner. That would be the preferred way of eating. How many people actually eat that way is cultural. Most of us eat the reverse. Okay? In my culture, which is, I lived pretty much all my life in Central and South America. One of the things that we unfortunately learned, and it's a bad habit, was in Argentina, was that the people started eating their dinners at around 10 o'clock at night. Okay? And that was the biggest meal of the day. And you'd have a very small breakfast, usually a croissant, and then you'd have a cup of coffee. Lunch became so medium, but then dinner was like this huge extravaganza, and you'd get used to eating almost every night at 10 o'clock. So bad habits are hard to break. So I can feel for these people. It becomes an issue with obesity. It's actually very difficult to treat. Cardiovascular effects of chronic obesity, though, is very significant. It causes a lot of hypertension problems. Eventually, that increases the risk of developing strokes and renal failure. They also have effects in hypercholesterolemia and hypertriglyceridemia, which leads to advanced atherosclerotic coronary artery disease, as well as peripheral vascular disease. They get cardiomegaly from chronic hypertension, have increased risk of developing congestive heart failure, pulmonary hypertension, sudden death, DVTs, and as well as peripheral and cerebral vascular accidents. Cardiovascular hypervolemia is due to an increase in total body surface area. So the person has to increase their cardiac output to maintain that perfusion level. So cardiac output can actually increase by as much as 0.1 liters per minute per kilo of additional adipose. So it's not benign. The heart has to work a lot harder. If you have to look at somebody who's morbidly obese, they have to be in pretty good shape to actually get up. Okay? Imagine if you were to do the same thing that individual was doing. I saw somebody the other day that weighed 650 pounds. Okay? And the guy actually got out of bed and started walking. He made it about 100 feet. I was actually duly impressed. Okay? The reason I was duly impressed was because if I had to put a 400 pounds of weight on me, I couldn't even get off the floor. Okay? So these people are pretty strong if you think about it. Okay? Now, the problem is that they can't get rid of that 400 pounds. Okay? And that's what's going to end up killing them. Okay? So insulin resistance becomes an issue. They tend to get hyperinsulinemia, which causes sympathetic activation and increased pressure response to norepinephrine and angiotensin II. Obesity, there is genetics in the environment, okay, but genetics play a very big part of it. The other thing that's really interesting that I recently read and actually watched on TV was what they called transgenetic mimicking, or something like that. It involves basically that your great-grandparents or your grandparents actually affect your likelihood of being obese. It actually skips a generation. And I don't know how that essentially works. When they were explaining it to me, I still couldn't get it. But they had the genetic principles behind it that somehow the gene that causes obesity is activated based on 2 generations back. Okay, so if your grandparents were starving, your chances of having obesity is very high. Very high. Okay, because people that are starving, what would be a good gene to activate? A gene that would be able to absorb more food and hold it and convert it into fat, more rapidly store it. So they know that people that had history of severe malnutrition for prolonged periods of time in the grandparents' age, then the grandchildren are the ones that are getting obesity at a very high incidence. Okay? So it's associated with that, which is kind of interesting. It's a really cool kind of stuff. I saw it in Nova about 6 months ago. So it's an interesting study. Now we don't have to blame our parents anymore. Now we can blame our grandparents. Okay? Anyway, that's a joke. You can get inflammation, and you get the sympathetic nervous system becomes an issue with natriuretic hormones. You get increased renal salt and water retention, increased blood volume, and you get sustained hypertension and vasoconstriction that takes place. Eventually, what you'll see is you'll see dietary deficiencies. You get also insulin resistance, which makes the obesity become more of a problem to try to control. And you see an increase in salt retention. Cardiovascularly, the hypertension leads to a concentric LVH with poor ventricular compliance. Diastolic effects on the heart as a consequence, and increased risk of developing congestive heart failure. We've sort of discussed this already in cardiovascular, but this is strongly associated with morbid obesity. The arrhythmogenic effects are due to hypoxia, partly because these people have high incidence of hypercarbia, because they can't ventilate, their FRC is significantly reduced. So that's another issue. So syndrome X is the metabolic syndrome versus obstructive sleep apnea. What you see is obesity leads to a metabolic syndrome, and these other syndromes are inducing hypertension, insulin resistance, and pro-inflammatory oxidative stress. What sort of want you to understand from this is that there's a syndrome that has metabolic effects and that also are associated with other things that will eventually affect the airway. Obesity eventually leads to cor pulmonale, which means that your right ventricle begins to fail. It's mostly due to pulmonary vasoconstriction that occurs due to reductions in FRC and the effects on the actual pulmonary vascular, hypoxic pulmonary vasoconstriction that takes place. Eventually, in some disease processes, you actually will get increased intimal fibrosis, and this leads to right heart failure in these individuals. Respiratory effects is one of the things that you have to be concerned about is obstructive sleep apnea, okay, OSA. Obstructive sleep apnea can also be associated with what's called obesity hypoventilation syndrome, which is also called Pickwinian disease. Okay? Pickwinian disease, the reason it's called that way is because of a character in Charles Dickens' novel called Mr. Pickwick. Mr. Pickwick was a man that was morbidly obese, and he would spend most of his days sleeping because at nighttime he couldn't sleep well because he was hypercarbic. Okay? So as a consequence, these people have a higher incidence of developing hypersomnolence, and they tend to fall asleep in the middle of the day, or they may actually fall asleep while driving. These people have, of course, a higher risk of developing hypercarbia post-anesthesia. They are developing a significant degree of restrictive lung disease from the actual fat overlaying over the rib cage. Obstructive sleep apnea is actually fat deposition that actually causes cessation of airflow. It could be from fat that develops around the neck, including inside the pharynx and the larynx. Okay? So you get pharyngeal and neck adipose tissue development. You get also a decreased pharyngeal muscle tone during deep sleep, which then becomes symptomatic in these people that already have narrowed airways. So this becomes a real issue for these individuals. This is somebody who has obstructive sleep apnea. And I want you to particularly pay attention to the actual positioning of this individual. This is typical what happens in the OR. You'll see somebody be put that's morbidly obese, and you'll even put even a normal shade headrest underneath, and you'll say, the person's okay. This is what they look like then. Okay? Their breasts are higher than their nose, okay? And their belly is above their nose. That is not a sniffing position. Okay? The reason this is happening to the individual is the way fat deposits in the human body. Okay? The fat does not deposit in the back of your head. Okay? So the back of the head, really, its size is not increasing dramatically with morbid obesity. Where it actually develops is it develops on a hump over the chest. So they get like a buffalo hump. And what that does is when you lay them flat, it puts your head back. Okay? And if you try to intubate this individual, it'll be almost impossible to extremely difficult. Okay? So all you have to do to fix the problem is something so simple that people don't do it. I don't understand. And it's this ramp. You can make it, you can buy the ramp, okay, or you can just make it yourself with blankets, which is what's done here. Okay? See, the blankets are stacked up on top. And then when you come to the lateral aspect and you look, this same person now is actually in a proper sniffing position. This person will be easy to intubate. It'll go from being extremely difficult to actually easy. Once you learn that trick, it makes all the difference in the world. I one time arrived to a code, actually a few months ago, and when I got there, they did the first thing that they always do at a code. They pulled all the pillows away. So they're trying to intubate with this patient like this. And nobody can see anything. So the first thing I do when I walk in the room is says, step out of the way, pull her up, throw 4 pillows underneath her back, put her in sniffing position, and intubate her in 10 seconds. Everybody's going like, oh, wow, you're so good. Dude, I'm not good. I know this versus they don't. Okay? So that's what makes you look really very much proficient while everybody else looks like they don't know what they're doing. Such a simple little trick. It makes all the difference in the world. Now, one of the things that happens with obesity like this is that your tongue gets very much enlarged, so it becomes an issue sometimes controlling the tongue. So you have to get very proficient with your blade of pulling the tongue to midline and out of the way. So you've got to make sure that you actually grab the tongue properly as part of your intubation process. The actual distance between the uvula and the tongue becomes very close, and that causes severe degrees of snoring. And you can see the epiglottis almost disappears into the tongue in this individual. So sometimes Mac blades can have a hard time finding the vallecula in these processes. Eventually, the substance sleep apnea causes hypoxemia, which causes an increase in the release of HPV, which is hypoxic pulmonary vasoconstriction, which then causes the actual pulmonary hypertension. The other thing that occurs from the chronic hypoxemia is that a person increases their red cell count, which causes polycythemia, okay, which increases the risk of developing clots and all sorts of other issues. The person usually complains in the morning of having headaches. Okay, usually it's an indication that they've developed hypercarbia in their sleep. They usually don't feel like they got rest, again, because they've been waking up all night long. They just don't remember it, but they've been waking up intermittently to try to breathe again. They have a much higher incidence of developing heart hypertension with strokes and coronary artery disease. And eventually, if you don't treat this, they develop into chronic pulmonary hypertension with right ventricular failure. This is Mr. Pickwick in the picture of Charles Dickens. That's what he actually looked like. So obesity, hypoventilation syndrome, or Pickwinian syndrome leads to chronic respiratory acidosis, desensitization in the central nervous system, and then you get what's called central sleep apnea, where the person doesn't respond appropriately to CO2 levels. Hypoxemia becomes their main respiratory drive mechanism, and a lot of times they present with significant respiratory as well as metabolic acidosis and chronic hypercarbia. Polycythemia is also very frequent, as well as pulmonary hypertension, which is due to the increase in HPV vasoconstriction of the lungs. Daytime somnolence is very, very common. Okay? Obesity, if you look at their procedures that we actually treat this, we do a uvulopalatal pharyngoplasty, okay, which means that we take the uvula, cut it out, okay, and then we suture the upper wall like this. Okay? As you can imagine, that sounds like a real thing I want to sign up for, right? Okay? It hurts. Okay? Anybody who tells you that it doesn't hurt is lying to you. Okay? This is a big procedure, very uncomfortable for the individual, but it can make a significant improvement in this individual's life. Does it always solve the problem? The answer is no, but most of the time it helps. A lot of these people have to, they recommended, of course, weight loss, but if you've ever tried to lose weight, it isn't easy. Okay, it's not as easy as people tell you it is. And, it's also associated with a lot of negative values that you're a weak person if you're heavy, and that's not necessarily the case. CPAP is a treatment choice. The problem with it is very uncomfortable to sleep with it at night. It's a mask that you put positive airway pressure and continuously put pressure to keep the airway open. Sometimes people will take oral airway devices. That's usually not tolerable. They can take nighttime oxygen as well. Then they also have what's called the genioglossus advancement. It's a pretty big procedure. What they do is they actually cut the mandible, and then they pull the genioglossus muscle and pull the epiglottis forward, and then they rescrew it in place. Okay? That's not a small procedure. It changes the way your voice works and everything, but it's actually been found to be helpful in some individuals. So this is what this picture is. So in case you work in a place where they do the genioglossus advancement, just know that your airway is going to be a concern afterwards. You may have some degree of compromise immediately afterwards. Obstructive sleep apnea and perioperative concerns is that it's very sensitive to central nervous system depressants. These people will fall asleep on a dime. I tend not to give these people pre-medication because of that. They also can be very difficult to intubate. So reverse Trendelenburg does not help. It's not appropriate to do somebody in reverse Trendelenburg position. It's not a ramping procedure. Okay? What you're trying to get is a person into a sniffing position. All you're doing by doing reverse Trendelenburg is you're just altering where the head position is, and when you think that it's appropriate, it's not. Okay? So it's really the ramping that makes a difference. Sometimes you'll have to do minimal muscle relaxation. You have to do them awake. Most of the time, we do these under rapid sequence and get them intubated quickly if we think we can get away with it. Okay? And we usually use succinylcholine, so in case we get in trouble, we can get out of it. The other thing you got to be very careful is you want to make these people radically reversed. They're right at the borderline, so if you don't reverse that person adequately and they're not fully back in their muscle tone, you're going to fail. Okay? Make sure that you pulse oximetry, monitor pulse oximetry, and watch your oxygen, because some of these people have central apnea syndromes, which is if you give them oxygen, they'll stop breathing because they're really O2 sensitive. If you can get away with using non-opiate analgesics, that's a preferred method. So narcotics can become very sensitized and cause significant CNS depression and stop breathing. Pulmonary, remember that it's a restrictive disease for one thing. You have a low compliance in these individuals, so the lung volume is actually significantly reduced. You have a significant reduction in the functional residual capacity, more due to the expired respiratory volume. Expiratory reserve volume is significantly decreased. It exponentially falls with increasing basal metabolic, body mass index, and you can get rapid desaturation in these people with apnea. So that's another concern. Low FRC accentuated by general anesthesia is also seen with 50% of individuals that have obesity. Pulmonary-wise, they also have an increase in closing volume. Okay, so their closing capacity pretty much approaches FRC. So they get small airway closure occurs at the end of expiration, which causes wheezing, and you get a significant amount of VQ mismatch, which leads to hypoxemia. The increase in basal metabolic rate also increases your oxygen consumption needs, which leads to a more rapid desaturation as well as an increase in CO2 production. And there's always, of course, an increased work of breathing because it is a restrictive disease process. So these people have usually increased respiratory rate with a smaller tidal volume. Endocrine-wise, things that I'm not going to go into a lot of detail is that they're going to go if they have Cushing's syndrome, they have diabetes, a much more higher frequency, as well as the reason they may be obese is because of hypothyroidism. That's another thing to be concerned about. What you're seeing is that things like that will cause more production of obesity will be insulin resistance, okay? And these people tend to have higher levels of sugar as a consequence. Again, I'm not going to go into all the hormonal effects. This is to show you that there is lots of different hormonal effects. I'm not going to go into it, there's not enough time. I'm going to keep moving along. GI-wise, it affects the hiatal hernia. There's an increased incidence of hiatal hernia in these individuals. There's an incidence also of inguinal hernias because when they cough, their lining on the wall becomes thinned, and so they have an increase in development of inguinal hernias. They also have an increased incidence of umbilical hernias as well. They have also a very high incidence of developing cholelithiasis with cholecystitis. And one of the things that you see with the women is we call the 4F club, which is female, fertile, fluffy, and 40. That's your highest risk for developing gallbladder disease. Okay? So just so you know that one. That's one to memorize for your test because that comes in all the time. Increased gastric residual volume leads that you have increased risk for aspiration. You have increased insulin resistance as well as fatty liver infiltration can be devastating in the way that these people break down compounds. You would think that somebody with obesity, their liver would actually be functioning properly, but actually it's not. If you take a goose and overfeed it, what do you get? You get great liver, fatty liver, which they make, I think, vichyssoise is what they call it. Foie gras, right, foie gras. So it's actually a delicacy. They actually take the actual goose, put a tube down his esophagus, and they overfeed him. So essentially it gives you the same kind of thing with obesity. You get a fatty liver infiltration. Musculocutaneous-wise, they of course have your joints are not made to carry that kind of load. Like I explained to you before, imagine 400 pounds being applied to your back and carry that along. That's going to cause your joints to break down. So these people have a high incidence of developing severe osteoarthritis. And then we're having to do total knee replacements on these individuals and total hips. So you imagine how high risk these individuals are. Okay? When you're putting somebody who's 400 pounds under a spinal, you have a hard time. Trust me. It's not going to be an easy case. Okay? And you're going to be expected to do those cases. The other thing, too, is they already have chronic back pain because what's happening to their spine. It's compressing. So is it difficult to do a spine on these individuals? Absolutely. Sometimes you can't even get the needle in between. It's just that tight. Okay. Cancer also has an increased incidence with obesity. You have breast cancer for women, prostate cancer for women, for men, cervical, uterine, and colorectal cancer is also evident. We think that it's related to target cells actually get an increase in receptor bioavailability, and you get apoptosis, which is cell necrosis, and increased cell proliferation, which increases the development of tumor development. Okay? So you can go into all this. The book goes into this. I think this is all a bunch of nonsense in the sense of what we do, so I don't ask you this on the test. Okay? I just have issues with this kind of book in the sense that sometimes they go into too much detail about something that you don't need to know. Okay? This is the stuff that you're not going to carry with you the rest of your life. So I wish they would spend more time saying, okay, what is it, the ramping? How do you manage ramping? How do you manage the airway? What are the considerations in this kind of disease? I think that book would be better served in writing that kind of stuff down, not into all this other stuff. Perioperative, okay, things that you have is obese airway. You have fat cheeks, okay, fat neck, okay. The pharynx and large tongue may all make it more difficult, okay. So these people are more difficult to mask. They're more difficult to maintain their airway open, okay. So these people have a much higher risk of being difficult to intubate as well. They also have a much higher risk for aspiration, so you have to do everything you can to prevent aspiration. This is a money slide, okay? This is what I want you to really know for obesity, okay? You have to put these people on H2 receptor antagonists. You have to consider giving these people non-particulate acids, and then definitely put them on a proton pump inhibitor. You want to decrease your risk of aspiration as much as possible. Understand that these people have a rapid desaturation due to low FRC, an increase in total oxygen consumption. They have high closing volumes and they have closing capacity that reaches their FRC as a consequence. Baseline hypoxia may become a problem, and you have significant VQ abnormalities in individuals. These people actually tolerate PEEP and do very well with PEEP, as well as CPAP. CPAP should be a very high consideration if you're letting somebody spontaneously breathe. I am not a fan of letting somebody who's morbidly obese try to spontaneously breathe unless you add CPAP. Okay? You must add a little bit of pressure to make sure that the lung doesn't collapse. If you don't, when you let that person spontaneously breathe, in 10 minutes you won't have any lungs. And then you'll be struggling to keep the saturation up. Okay? And to really re-expand the lung, how much pressure does it take to re-expand the lung? 40 centimeters of water pressure. For how long? 8 seconds. So you got to hold the bag for 8 seconds at 40, and you got to keep squeezing the bag to maintain a 40 pressure. That's a lot of pressure. Okay? Will it cause cardiovascular instability? The answer is no. Okay? As long as you keep it under 8 seconds. Okay? So, get the belly off the lungs. So do reverse from downward as much as possible in these individuals, or at least putting them in a sitting up position. The altered pharmacokinetics as well is important. The liver tends to have decreased function. You have increased blood volume, which increases your volume distribution. So fat is, remember, is poorly perfused, but it doesn't mean it's not perfused. It's still being perfused. So that means greater amount of red cells, greater amount of a lot of things. Remember that ideal body weight dosing or total body weight should be consideration. Depends on what you're injecting. If you're looking at from emergence values from general anesthesia, you have slow elimination of volatile anesthetics that takes place because a lot of the volatiles basically go to the fat. The drug that actually is safe to do is better to use is desferrine. So desferrine is really the one I would use. Sevo is also fairly safe, but after about an hour and a half begins to act just like isoflurane, so I don't recommend it if it's more than an hour and a half case. Desferrine is really the better choice of all of them in the sense of volatile anesthetic. It doesn't penetrate into the fat as much. Nitrous oxide should also be used as it has a low blood to gas ratio of about 0.43. So that's another one that I would consider using somebody who's morbidly obese. Sometimes people use dexmedetomidine, which is an alpha-2 agonist. for sedation, analgesic, and anxiolytic properties. We don't use that here, but it's been recommended now more recently with obesity patients. Model-wise, you're looking at high perfusion organs. Okay? This is when you inject the medication. It usually goes to high perfusion, and then it then goes next to the medium perfusion, and then eventually goes to low perfusion. The high perfusion stuff then reperfuses through the liver, and it gets broken down, and eventually gets to the rest of the organ systems. If you look at obesity, the fat has a very high amount of volume distribution. Okay? So does it affect the drugs that go into high perfusion states? The answer is no. Okay? So like propofol, you're not going to change the dosing that much. Okay? It's going to be weight based on that person. Okay? Normal body weight. But if you have a drug that's keeping around, that's going to eventually accumulate, it becomes an issue with morbidly obese patients. So here's what I want you to do. Okay? What you want to think about is drugs that are going to be going to very high blood flow areas fast. You should base them based on ideal body weight, not on their real weight. Okay? So propofol, you shouldn't have to give 700 milligrams of propofol to somebody who is, 600 pounds. You will kill them. Okay? Because what you're trying to do is you're trying to affect the brain, which is going to get there in 35 seconds as soon as you inject it. Okay? So try to go with ideal body weight in that individual. Okay? Thiopental is the same thing, but in a sense, thiopental will actually perfuse to fat areas as well. So you use total body weight in that individual. Midazolam, usually total body weight. Succinylcholine, use total body weight as well. What you see in morbidly obese patients is plasma cholinesterase activity is proportionally increased based on body weight. So you have to increase your dosing to that total body weight value. But propofol should be ideal body weight. Okay? If you're doing a maintenance where the drug is wanting to be constant, then you base it on total body weight. Okay? But this is important, this difference of these two. As for the drugs that are aminosteroidals, okay, such as vecuronium or rocuronium, you use ideal body weight. Okay? Versus things like benzoisoquinolones, such as atracurium and cistocurium, you use total body weight. Okay? Fentanyl and sufentanil, which are very potent drugs, you use total body weight. And remifentanil, because it's getting to the brain and then broken down so fast, you use ideal body weight. Positioning. Do not exceed the bed weight limit. Never seen, you don't want to call timber. Okay? When they fall off the table, it's devastating. I had one of my friends who had a herniated back because he saved somebody's life. Okay? But it was stupid. And what they did was they put the person that weighed 480 pounds on a bed that can only hold 400, and then the surgeon asked them to put the bed all the way up so they could do the hip surgery, and the patient started going off to the side. My friend stepped in front of him to try to save the guy's life, and he did. He stopped the guy. He actually rolled on top of him. The problem is the bed rolled on top of him and gave him a herniated back, and he's no longer practicing. So you don't do that to yourself, okay? Because you're going to want to step in to save this person's life. You can do something stupid, okay? I've seen also people fall off tables. The actual orthopedic tables are very dangerous. They literally will come right off the table. You got to strap them down. You got to be very careful. Those tables are very narrow. They're about as wide as this. Most of you, if you lay down on that table, will be consuming almost 90% of that surface area. If you put somebody who's morbidly obese, now they'll overhang by about 30% on each side. And if you put that person to sleep, okay, and there's a little bit of somebody decides to push on the belly, and it shifts the weight off, the person just literally starts rolling on you, and it's on the floor. Not a pretty sight, and it's very dangerous to the individual. You can break their back and break bones. You know, if they hit their head, they're dead. So you got to be careful. These people also have a much higher risk for pressure sores. They also have an increased risk of neural injuries with diabetics because they get brachial plexus injuries, ulnar nerve palsies, more frequent ones. And you need to place your head up, if possible, for a better FRC. It's not going to help you with the aspiration, but it's going to help you with FRC. And make sure that you ramp the individual up before you start to get yourself your maximal ability to intubate these individuals. Perioperatively, regional may be really challenging, as I was telling you before. Now you're actually having to use a very large needle to get to even find the spinous processes. You won't even know where the spinous process is at because you won't be able to feel anything. Okay? I had one time somebody tell me I had to put an epidural in somebody that weighed 600 pounds or 550 pounds, something like that. This lady, she had to have big abdominal surgery. Everybody told her there's no way you can have surgery. You'll never tolerate it. Her breasts alone weighed 45 pounds apiece. Okay? So we had a very hard time ventilating her in the operating room. Her peak inspiratory pressures were at 50 the whole time the case was being done. And at the end of the process, we had to try to get her extubated. We couldn't, so we took her to the ICU. And when we got her to the ICU, what actually finally got us extubated was we put an epidural in her. We actually used a very long epidural needle that was a 20-centimeter needle. The normal needle is 10. The 20-centimeter needle is that big to find it. Okay, we got lucky, put it in, okay, and it took care of her pain. So then we tried to get her breathing. That didn't work. Sat her up. That didn't work. Okay, so then we figured out, we did something innovative. We put a suture through each breast, hung it up on actually IV stands, took the 45 pounds, which is 90 pounds of weight off her chest, and all of a sudden then she could breathe, and we got her extubated, and she ended up leaving the hospital about 2 weeks later. So I'm not kidding. This stuff is fairly serious. This is not a joke, okay? It can get you into serious trouble, how much difficulty you can get into these individuals. And once you keep them intubated for prolonged periods of time, what happens to their muscle tone? 10% decrement per day. So that's bad news for somebody who's morbidly obese. Okay, so just realize that also they have an increased risk for postoperative ventilation. Means we require them to be on ventilators. Post-op hypoxia is also an issue. You really need to consider using short-acting inhalational agents such as desferrine and nitrous oxide are really the primary agents of choice, including SIVO. Remember, the volatile anesthetics have muscle tone depressant effects. So if you have this, which one is the least? The answer is desferrine, and nitrous is the least. Nitrous, of course, is not a volatile anesthetic, but of all the volatiles, the one that has the least muscle relaxation ability is desferrine. And that will be a consideration in your mind in some cases where you need muscle relaxation. Desferrine is not an appropriate agent to use. If you want more muscle relaxation, use isoflurane. SIVO actually has more muscle contraction ability. The difference, though, is that ISO is used more because it's more potent. Okay, but if you look at the actual blood to muscle partition coefficient, it's much better for SIVO. But the reason we use ISO is because it is more potent. Okay. Residual neuromuscular blockade has to be gotten rid of. We've got to adequately reverse it in these individuals. And there's a much higher risk for wound infections and postoperative DVTs. Obesity, what you see is an increased uptake of the more soluble agents. When you used to use, the people that would die at very high rates in the old days, and when they were using chloroform and ether, were morbidly obese patients. These people did not tolerate anesthesia because they would stay asleep for days. The ether would stay in their fat. Okay? And especially if it was a long procedure, forget about it. They wouldn't wake up for days. They'd be like in a comatose state. So that's really not a good thing. So the newer agents are much better. Increased fat increases the blood flow directed to bulk fat and thus increases uptake. Fat also is now in a medium blood flow tissue like muscle in these individuals and into abdominal organs, so increased uptake into this fat. This leads to a more prolonged emergence through the gas storage in the fat. Bariatric surgery, there are certain centers that we have where we have exclusively, they do a lot of bariatric surgery. Okay? So hopefully some of you will be exposed to that and you get to know how difficult these people are to manage. Okay? You got to remember that these have restrictive disease. They have also decreased gastric compliance in early stage disease. What they're doing with these procedures is put a banding, or they're actually cutting and diverting it through the small bowel. Okay? They can do a combination Roux-en-Y and things like that. Now, most of the ones that we see nowadays is done with a banding effect, okay? And the access port actually allows you to increase the tone or decrease it by putting more fluid around it. So it actually is, in that sense, controllable, okay? The problem with these banding effects is there's a much increased risk of developing achalasia, as you can imagine. If it's done too tight, the peristalsis of the esophagus eventually gives up, and these people develop problems with their esophagus. Laparoscopically, these people are done. The problem with them is that when you put them in Trendelenburg, it becomes a nightmare of FRC problems, where you have a total reduction in FRC. So your peak inspiratory pressures rise very dramatically. What you have to do to actually get air in these individuals is that you have to increase your workload on the ventilator. That means that you have to spend more time pushing the same amount of air into the individual. So what we usually do is we'll increase the I time. So the inspiratory time is increased in these individuals, and usually the normal is around 2 seconds. We'll spend up to 3 seconds on inspiration, okay, to try to get more air into it. It gives you a prolonged plateau phase, and then you're actually able to get air in. Okay? So ventilation becomes really a big issue. The other thing is that you're fighting against this morbid obesity is the high peak inspiratory pressures. And consider using PEEP to maintain oxygenation, because as soon as the lung is expiring, it goes to collapse. So PEEP can really help you in maintaining the lung so it doesn't completely collapse on you. And then you have to reinflate the lung at very high pressures to try to get it back up. The next disease process is anorexia nervosa, okay, which affects about 5 to 10 cases per 100,000 people. In some countries, they actually take people with anorexia nervosa that's not treatable, and they actually euthanize them, which I was shocked when I heard that. Which is, they say it's a psychological problem that cannot be treated. I think that's a little bit extreme, but I've actually heard about it and actually read about it, so it's true. Females tend to have a much higher incidence with body images than males. As a consequence, they develop this disease process. But this is becoming also a male disease that we're seeing at higher frequencies as well. But we're getting both extremes. We're getting obesity higher and anorexia nervosa higher. The whole population is going to hell, it looks like. But and hopefully things will change. The body mass index is less than 17.5. These people have a real high fear for weight gain. They have really an altered perception. They think that even if they look like this, they say that they're too heavy. And it's really shocking when you hear a young woman tell you this, and it's part of your psych rotation. You're looking at her like, you weigh about 82 pounds, and you should be 130. And she's still saying that she's grossly overweight and that nobody will love her. It's interesting how people can look at things. Cardiac effects is that they have decreased myocardial muscle mass. Part of that is because they have so much protein malnutrition. Okay? They are not taking enough proteins most of the time, and as a consequence, the muscle and especially the fat is what the heart really wants. The heart doesn't like glucose. The heart really likes fatty acids in the bloodstream for its major power source. So if you deplete the fat in the person's body, the myocardium begins to fail in its functionality, and you have a decreased contractility. These people a lot of times will die of dysrhythmias and sudden death. The kind of changes you see is you see the muscle mass actually begins to decrease, so you get low amplitude, you get bradycardias, and you get hypokalemia may be evident in these individuals. Physical signs, you see this dry skin, the hair becomes severely thin, as what's called lanugo hair. It actually will change its coloration. Their skin will appear cyanotic and have very cold extremities. The body's trying to go into a starvation mode. It's trying to save the brain, so it's diverting blood flow away from the periphery to the central organs. They also get orthostatic hypotension, bradycardia, and autonomic nervous system dysfunction is very common. Metabolically, they see electrolyte disturbances, specifically hypokalemia, because a lot of these people not only have eating disorders, but they also vomit, so they have usually associated with bulimia, so they're constantly self-purging. They develop osteoporosis at a very young age, low estrogen levels, so they don't get pregnant. They also have fatty livers and cognitive impairment. They really begin to have an inability to understand the process that they're undergoing. So you have this whole effects that you see, neuroendocrine effects, cardiovascular effects. This is a nice picture, sort of way of looking at it. So if you like pictures, you can go through this. Bulimia nervosa is sometimes associated with anorexia nervosa, but not always. It's a binging and purging disease where the woman or the men vomit or use laxatives or diuretics. It's associated with certain amounts of depression and anxiety disorders, and a lot of substance abuse is usually associated with it too because they're self-medicating. It's usually done with recurrent binge eating, but some of these people don't lose any weight. And they can actually maintain their weight by overeating, but they just don't gain weight, but they don't develop into the anorexia. The problem with it is when you're chronically purging like that is that it begins to burn everything from your stomach upwards. So the actual esophagus begins to be burned out. The teeth will begin to degrade from all the acid, the enamel, and the teeth will become degraded. And you'll see these people have very, very severely bad dentition. The other thing that you can pick up on is they have a lot of halitosis because and you can smell like the vomit in there when you smell them around them. So some of them can hide it very well. They'll do mouth washes. If your kids are using mouth washes that you're having to replace every week, you got a problem. And that's how you would diagnose somebody usually. Is the girls would be very good about trying to cover up the odor, the constant vomiting. So you just got to be concerned about that, and you got to treat them, and you got to have a psychiatrist to help them. What you're looking at is there's binge purging and restrictive type. Okay, I'm not going to go into that detail. Just know that it eventually causes starvation and low body weight most of the time. Physical findings, you see hypertrophy of the salivary glands, so they tend to get like this big cheeks. They get dry skin, dehydration. They get the teeth problem I was telling you about. And they also get severe hypokalemias that can be arrhythmogenic in quality. So they get hypokalemic, hypochloremic metabolic alkalosis because you're losing all your acid, plus you're losing your chloride from the hydrochloric acid. Consequences, eventually you get cardiac dysrhythmias, and that's usually what ends up killing them. They may also get an aspiration pneumonitis that they develop as well. There's different populations in some cultures. This was actually the norm. If you were a Roman, they actually had places called vomitoriums. They would overeat all the time, and it was actually a sign of a richness that you would vomit after you finish your meal so you can go back and have more. So they actually had to set up a whole little area where you could actually vomit as a cultural thing. So, maybe we're not that different 2,000 years later. Neuroendocrine-wise, we have irregular menstrual cycles and decreased serotonin and epinephrine, which alters a person's sensorium. Digestive-wise, they have a lot of irregularities, constipation, and they get the loss of gag reflex, internal bleeding. You'll see ulcerations. Usually that's when we pick them up. They get severe esophagitis, and a lot of times they'll present with hematemesis from possibly Mallory-Weiss tear as well. Then you have binge eating disorder. You binge and binge again. Okay, you get recurrent binge eating, and these people will go from eating normal, and then they'll hit Friday night, and they'll be depressed. It's end of the week. They don't feel good, so they'll order 10 pizzas, and they'll go through 10 pizzas. Okay, so that's called binge eating. Okay. The eating habits are usually done when the person's alone. They do not do this socially. So that's another sign that the person may be significantly depressed. And they really are eating when they're not even hungry, and they continue eating even though they're stuffed. They feel guilty after they binge, so sometimes they purge, sometimes they don't. Okay? Some of them will then go into excessive exercising to try to maintain their weight, but most of the time, eventually with binge eating, you do start gaining weight. Then we're going to talk about malnutrition. Malnutrition is an indicator by albumin, which is a protein, which is, if you see the serum albumin less than 3 grams per deciliter. If you start seeing transferrin, which is iron protein carrier, is less than 200 milligrams per deciliter, or you see somebody immunosuppressed, may also indicate malnutrition. You're looking at about total 20% body weight loss of the ideal body weight. It may indicate nutritional support. It's indicated for about 1 week pre-op. So there's different kinds of malnutrition. There's protein malabsorption syndromes, or protein malnutrition, called kwashiorkor. These individuals develop low albumin levels, ascites, okay, peripheral edema, muscle wasting, depigmentation of the skin. This is a typical kwashiorkor kid. Okay? They get growth failure and they get hair changes. On the other hand, you can also have glucose deficiency, such as marasmus, which is a total calorie deprivation. Where do we actually see this? We're not going to see this very often in our kwashiorkor marasmus. Instead, we're going to get enteral nutrition support where people are not being nourished properly due to cancers or other things like that. What my attitude is, and the way I was taught, if your gut is working, use it. Okay? The way we would actually do it is that we would put feeding tubes under X-ray. And I was taught to do that as part of my ICU training, that you had to put it inside the duodenum. Okay? You would never feed the stomach, but you would feed the small intestine. Do not feed the stomach when your person's ICU and sick because they don't peristalse their stomach. But the intestine continues to peristalse and be very happy getting nutrition. Okay? So as long as we would put the tube feeding into the small bowel, we had no problems. Okay? If you are asked to do an anesthetic case and somebody's been tube fed and their tube feeding is actually in the small bowel in the portion of the duodenum and beyond, okay, usually in the early part of the jejunum, then you don't have to worry about risk for aspiration. Those people are not going to aspirate on you. But on the other hand, if you have the tube feeding and you see it's inside the stomach, you basically have a full stomach in your hands, and you have to wait 6 to 8 hours before you consider putting that person to sleep if it's an elective procedure. Okay? If it's not an elective procedure and you have to go to the surgery, then that person is an increased risk for aspiration, and you have to treat them an RSI. Okay? So there's a big difference between being enterally fed versus being fed in the stomach. Okay? There's fewer complications if you feed the stomach, if you feed the intestinal wall, okay, because you help maintain their normal GI flora. Okay? When you starve the bacteria that are there, they die, and what's replaced usually is with bad stuff. Okay? So you want to have adequate nutrition. But one of the things that we also used to do for our patients is that we used to give them Acinetobacter, which is a very benign bacteria that can be found in yogurt. Okay? So the active cultured yogurt has this bacteria in it that works very fine. So we give it to the patients and they would do much better. Okay? They tend to have much more sugar stable levels if you give them enteral feedings, but you do have to still watch your blood glucose levels, but they tend to be not as brittle if you feed them that way. But I'll just talk to you about surgery, about how to properly give somebody tube feedings. On the other hand, if you have to do total parenteral nutrition, that has a much higher risk. There's a higher risk of infection. There's a higher risk of causing electrolyte disturbances. So I don't like parenterally nutritionally giving somebody unless their GI tract can't work. Things like if you have small bowel surgery, then you can't, and then TPN is appropriate. Okay? Peripheral IVs can only accept around less than 2,000 kilocalories per day, and they can only accept about 900 milliosmoles per liter for about 14 days. So isotonic solutions are only available with peripheral IVs. So you have to put central lines in these individuals if you want something more than that. Okay? Now, where do you need to give somebody more than 2,000 kilocalories a day? And there's indications. Most people that are post-surgical are catabolic. They're consuming so much nutrition at that point. Even if you gave them plenty of nutrition, you would never keep up. The person stays catabolic no matter what you do. Okay? Burn patients can then lose as much as 10,000 to 20,000 calories a day. That's a lot of calories. Okay? So imagine trying to push that into the individual. That's pretty difficult. There is complications associated with TPN. If you are not careful, you can get into hypokalemia, hypophosphatemia, hypomagnesemia. All these things, just, you don't have to memorize that. I just want you to know that there is significant complications and that you've got to be aware of it. And one of the things that I would recommend you do if you're taking somebody in for surgery for a TPN, the things that you really need to know is, one, check your electrolytes. Okay? Correct them before you start if it's elective. Okay? And third, don't stop the TPN. If you stop the TPN before you go to surgery, then when you start the case, the person is going to bottom out. Their sugar level is going to drop like a rock. Okay? At that point, they're receiving insulin usually through the TPN, And if you stop giving them glucose at that point, their sugar levels will drop precipitously, and you'll be hypoglycemic, and you won't be able to diagnose it intraoperatively with catastrophic effects. So that's what I really want you to know. Okay? The other thing that you also have to know is that if you're giving a lot of calories to an individual, calories get converted into CO2. Okay? So somebody who's hypercarbic can sometimes be treated by altering their TPN or enteral feeding to more of a high protein-rich compound that has less CO2 production as a side byproduct. Okay, and you can still provide them with adequate nutrition. Okay, and that's what Pulmicare is. How many people know what Pulmicare is? It's enteral feeding for people with pulmonary disease. That has high protein, low carbs. The reason it has low carbs is because CO2 is converted, and then the person has to blow off through the lungs. And if you have limited ventilation capability, you can't get rid of the CO2. And you'll see that every once in a while. People forget that. And the patient will come in with a hypercarbia of 55, and everybody's trying to force it out, and they can't get it out. All they have to do is just change the nutrition, and all of a sudden the problem goes away. Okay. Infection, sepsis may be also, of course, a problem. If you don't feed the gut, there's more of a chance of developing bacterial translocation, because healthy enteral cells in your GI tract keep the bacteria out. If you don't feed them, they start not holding themselves together properly, and then bacteria pass through. And it's usually the nasty stuff that gets through, E. coli, that's pathognomonic, and you got big problems in your hand. Vitamin deficiency, what I'm going to do is I'm going to finish this section today. I'm not going to stop till I'm done here. And then I'll put the other lecture online tonight or tomorrow, and you guys can start looking it over. Vitamin deficiencies can be, there's two kinds, there's fat-soluble and the water-soluble vitamins. The fat-soluble vitamins are ADEC, vitamin A, D, and E, and K. They're absorbed with lipids, so they need to be absorbed through micelles and chylomicrons. So if you don't have fat absorption, such as malnutrition problems from that, you can get significant fat-soluble deficiencies. As for water-soluble, these are absorbed through special transport proteins. B12 is the most common in the sense that it's bound to intrinsic factor from the parietal cells to be absorbed. So if you lack parietal cells in the GI tract, then you can cause problems with B12 deficiency. And that becomes important for us. I'll show you why. B1 is thiamine deficiency. It's called beriberi disease. It's found in a lot of patients that are chronic alcoholics. See low SVR, so the person has hypotension, high cardiac output. Okay. They'll get polyneuropathy, and they get stocking glove distribution, which is called dry beriberi. If you get edema, tachycardia, and EKG changes, the person will develop congestive heart failure, possibly. If they get what's called wet beriberi. Eventually, with B1 deficiency, you get Wernicke's ataxia, which is you get confusion, nystagmus, and eventually, if you don't replace it, they will go into a comatose state and never wake up. They also have Korsakoff syndrome, where they have retrograde amnesia, and they develop confabulation, which means they're making things up all the time. And a lot of times they'll get hypotension from inadequate sympathetic vasomotor response. My personal favorite is this one, B12 deficiency. Okay? And the reason vitamin B12 becomes important for me is because we provide people with nitrous oxide. Okay? It's a necessary coenzyme for DNA synthesis, so it's very important for DNA production. It's important for also myelin production. Okay? So if you lose B12, you lose DNA synthesis plus myelin production, so it begins to affect the nerves. It's also important for hemoglobin production. It's seen very much in strict vegetarians, and they get this deficiency where they get a hypochromic macrocytic anemia, and they begin to demyelinate their large nerves and develop significant peripheral neuropathies. Okay? Nitrous oxide, unfortunately, shuts down B12. Okay? And then it becomes a big problem. So somebody who was already lacking in it is going to become very much symptomatic when you give them nitrous oxide. Pernicious anemia can be another cause of B12. What leads to B12 is atrophy of the mucosal wall, lack of intrinsic factor, and then you get malabsorption of the B12. Oops. So here's what you see. B12 has to be bound, and eventually it's bound to the intrinsic factor, and then it gets absorbed into the GI tract. Things that eventually lead to problems is if you don't have the receptors or you don't have the intrinsic factor, then you develop B12 deficiency. But in other words, it means that you have a fairly complex system that involves the stomach. So if you do a total gastrectomy on somebody, what's their chances of getting vitamin B12 deficiency? Very high. Okay? What leads to the anemia, you can go into all the detail. I'm not going to go into it specifically. Just know that methionine synthetase is a very important factor that's B12 dependent. Okay? So let me get back. Lack of B12 leads to inhibition of methionine synthetase, which then means that methionine cannot be converted, okay? And which leads to lack of myelin production. Okay? If it also, without methionine synthetase, without the B12, you don't get the formation of tetrahydrofolate, which eventually leads to no purine synthesis, which affects the DNA and affects the actual production of red blood cells in a qualitative way. Okay. This leads to these elevations in these kind of compounds. You can look at this in this slide. What eventually drops levels of serotonin, norepinephrine, and dopamine. It decreases your myelin production. And eventually causes your lack of purine synthesis, which affects your DNA. Eventually, what it also does is that the breakdown products of DUTP, which is urine triphosphate, is increased dramatically. Instead of being used to make DNA, now it's reverted back to an increase in RNA production, which then leads to protein synthesis being uninterrupted. Sorry, let me get that out of the way so I can see it. So it leads to protein synthesis being uninterrupted and leads to an overproduction of certain kinds of proteins. And then leads to what's called a hypochromic macrocytic anemia, which we'll talk about again when we talk about more anemias. What leads to demyelination is that you see that this adenylacetylcobalamin is affected by B12 cofactor, so you don't have that. So what you end up having is accumulation of these compounds, which then leads to poor myelin formation. Nitrous oxide, here's where the slide that's really worth something is this one. Okay? You can go into all these mechanisms and memorize this, but I don't want you to do that. I just want you to know that we know how the mechanism works, that it is available. If you ever want to have a discussion with somebody about this in a major, M&M meeting or something like that, you can actually impress people by showing them all this stuff. But really what's important is that you have to understand what's going to be the effect in somebody who's vitamin B12 deficiency and giving them nitrous oxide. Okay? Nitrous oxide basically oxidizes cobalt core in vitamin B12. This inactivates the methylcobalamin and inhibits conversion of homocysteine and depletes what's called S-adenosylmethionine. This leads to an elevation of homocysteine, okay, which indicates to you that you have a vitamin B12 deficiency. It affects serotonin, norepinephrine, and dopamine, and it affects myelin production, and it leads to pernicious anemia. So that's really what you have to be concerned of. This is the effects of having somebody with B12 deficiency and added nitrous oxide. You can cause a significant problem. Okay? So who's at risk? Okay? Not everybody. So most people, you give nitrous oxide, you don't have to be worried about. But people that have vitamin B12 history of deficiency, but if they're getting vitamin B12 shots, do you really have to worry about it? The answer is no. Okay? But if they have a high-risk group, then you may want to consider it. Okay? If the person has HIV, then you have to be concerned. Patients over the age of 65, which is almost everybody, but if you look at people here in Naples, almost everybody's on B12. So it's not an issue. Okay? If the patient has multi-infarct dementia, then you have to really consider them getting an additional dose of vitamin B12 if you decide to give them nitrous oxide. What you see me do in the operating room is if I think somebody's B12 deficient, I will ask them to put in what's called a banana bag, or what's called a multivitamin bag before you start the case. Okay? The banana bag, the reason it's called banana bag is because it's yellow. When you put the vitamins into the IV bag, it turns bright yellow. Okay? So that will take care of the problem, and you won't have any issues with this. What will happen if you give that person nitrous oxide, they will develop paresthesias and poor manual dexterity up to 1 to 3 months after the nitrous oxide exposure. So it's going to take a long time for you to see it. And by that time, the person's home. Okay? So that's a concern. Onset is often a sensation of cold, numbness, and tightness at the tips of their toes and then their fingertips, rarely with lancinating pains. Simultaneous involvement of the arms and legs is uncommon, and the onset in the arms is even rarer. It tends to happen more in the feet. Paresthesias are ascending and usually involve the trunk, leading to cessation and constriction of the abdomen and the chest, and untreated patients may develop limb weakness and ataxia. Yes?
If, let's just say that we've done a procedure and we think the whole lesion within can we treat it without that?
Yep. Doesn't really matter, just to try to get B12 in them as soon as possible. Okay? So you get these hematological and as well as psychiatric abnormalities. What you want to do if you think you got a problem, you measure serum B12 and folic acid levels. Okay? Folic acid levels are low, then you want to treat with folic acid. If it's normal, but your serum B12 levels maybe show that they're low, you treat it with B12. And so this is a way of actually showing you the possible problems associated with this and how to treat them. The route of administration usually is oral. You can get B12 and it works fine. If the person cannot absorb it GI-wise, then you give it intramuscularly. That works very well. This is for people that have been poisoned by high doses of nitric oxide chronically. This is usually from abuse that you see this from. This is now usually what we see in the operating room, so you don't have to worry about in that respect. The next few is, I'm almost done, is vitamin C deficiency. This is scurvy. Scurvy is a disease of sailors. Okay? If you look at the old English terminology for naval men, what were they called? The British Navy, their naval men were called limeys. How many people knew that? Nobody knew that. Okay, somebody's not into military history. Some of you. Okay, good. So the British naval men were called limeys. Why? Because part of their treatment was every day they would get a lime to suck on. Okay? And the British Navy never had problems with vitamin C deficiency. They didn't tell that to the French, they didn't tell that to anybody else. Okay? They had scurvy, but the British didn't. Because what they figured out, it was a vitamin deficiency from lack of fresh vegetables and lack of fruits. So the way they treated it was they gave them limes to drink. So vitamin C is basically causes teeth to fall out, and they get a defective collagen, they get capillary fragility, petechia, and they get poor wound healing, so they tend to look like this. This is an old sailor. You see his teeth coming out, okay? They get sunken eyes, and they get really pale skin. Vitamin B3 deficiency is the lack of nicotinic acid, niacin, lysine, tryptophan, which they get skin sour. They get causes are things like carcinoid, high lecithin diet, alcoholism, and malabsorption. Usually it's a reversible confusion, irritability. GI-wise, they can get echinohydra, severe diarrhea, and dermatitis-wise, they get stomatitis, salivation, and urethritis. Pellagra is what you see. This is what you see, diarrhea, dermatitis, dementia, and death if you don't treat it. Vitamin A deficiency is poor night vision. The reason that I teach you this as well is because it does matter to us. Patients that have a high degree of vitamin A deficiency have a much higher incidence of postoperative nausea and vomiting. And so one of the questions that you may want to ask an individual is, do you see poorly at night? If they're telling you that they have a very high incidence of nausea and vomiting, my first question out of my mouth at that point is, do you have night blindness? Most people don't know what night blindness is, so you say, do you like driving your car at night? And they'll usually tell you, well, I have a hard time driving my car at night. I don't see very well. Okay, that's vitamin A deficiency. Okay, you also get dry conjunctiva, corneal destruction. If it's really, that's one of the leading causes of blindness in third world countries is vitamin A deficiency. Why? Because of rice, the way they switched to rice. The old rice that people used to eat in the third world countries was husk rice, which is where the vitamin A is at. Okay? The new white rice which is what most people like, because it tastes better. Okay? It doesn't have a crunchy, grindy feel to it. And most people like the nice texture of the soft white rice. The problem with it has very low levels of vitamin A. And if that's your primary diet, you go blind. Okay? So it's such an easy thing to treat. Just make people eat their husk rice again. And it was almost like overnight, in less than 30 years, blindness went up in these countries dramatically, simply because they went to refined rice versus their older rice that they used to have. The other thing that you can get is if you take excessive amounts of vitamin A. So if you decide to go on a trip to South Antarctica, or you go to the North Pole, don't eat polar bear liver. And stay away from walrus liver. Anything that's in the high cold areas, they have a very high concentration of vitamin A in their livers. Okay? If you ingest that, you will die. Okay? You will get irritability. The person will develop hepatosplenomegaly, anemia, and will begin to hemorrhage as well. So ingestion of polar bear liver. And guess what? Somebody found out the hard way, right? That's how they figured that out. Okay? They had a whole expedition that went up north. They were starving, and they ate a polar bear liver, and they all died. Vitamin D deficiency is the last thing I think we're going to talk about, which is rickets. Say poor calcium absorption, leads to poor calcium absorption, increased parathyroid, osteoclasts. So these people have bone remodeling, and you get this kind of effect where the kids get the widening gait. Again, I'm not going to go into all the specifics. We've done this before, and it's part of endocrine, so I'm not going to cover it. And vitamin E deficiency, it causes peripheral neuropathy, skeletal muscle atrophy. If you give overdoses of vitamin E, which is very common here, is because a lot of people take vitamin E to stop them from bleeding. Stop them from coagulating. So if you take too much vitamin E, there's a much increased risk of bleeding. So surgically, we recommend if somebody says that they're on vitamin E to stop taking the vitamin E prior to surgery. Okay? There's also an increased mortality rate with heart failure, and may actually prolong the PT in these individuals. And vitamin K deficiency, which is the fat-soluble vitamin, do not give IV or IM, so don't let anybody tell you to do that. It's a reversal for warfarin. Okay? The problem with it is somebody will tell you to give it IV or IM. It's a good way to kill somebody. I've seen people do it IV and get away with it, but if you give too fast an infusion, you can get yourself in big trouble. Okay? And that's it.